Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Start with a patient I saw not too long ago. She was 43 years old, successful, driven, had 2 kids, full career. She came in because she had gained about 15 pounds over the prior year and couldn't explain it. She was exercising more than ever. She had cut back on carbs. She was doing everything right. Her primary care doctor had checked her thyroid and told her it was fine. She was told she probably just was stressed. When I sat down with her and took a real history, I asked a few more questions. Were her periods changing? Yes. Shorter cycles, heavier some months, skipped occasionally. I asked, was her sleep different? Yes. She said not exactly hot flashes, but she'd wake up at 3 a.m. and lie there for 2 hours. Was she more anxious? She laughed and said she thought that was just her personality now. None of these things had been connected for her. No one had sat with her and said, this is perimenopause, and this is what it is doing to your metabolism. That conversation is what today's episode is about. I'm Dr. Thangudu, and this is Endocrine Matters. Let's start with the basics, because I think the word perimenopause gets used without anyone really explaining what it means. Perimenopause literally means around menopause. It is the transition period before menopause, which is defined as 12 consecutive months without a menstrual period. Perimenopause can begin anywhere from 2 to 10 years before that final period. For most women, it starts in the mid to late 40s. But for a meaningful number of women, particularly those under significant stress with certain autoimmune conditions or of certain ethnicities, or even with the family history of early menopause, it can begin even in the late 30s. The ACE, the American Association of Clinical Endocrinology, along with the North American Menopause Society, recognizes the menopausal transition as a distinct physiological phase, not simply a slow fade into menopause. During this time, estrogen levels don't just decline steadily. They fluctuate, sometimes dramatically. There can be months of high estrogen, sudden drops, unpredictable cycles, and all the symptoms that come with those hormonal swings. Progesterone tends to fall earlier and more consistently than estrogen, and all of this variability is, physiologically speaking, completely normal. What is not normal is that most women are never told any of this until they are already in the thick of it. And by the time they get the answers, they have often spent months or years attributing their symptoms to stress, anxiety, or just getting older. The symptoms of perimenopause are wide-ranging and frequently misattributed. Irregular periods are usually the first sign, but women also experience sleep disruption, often waking in the early hours without classic hot flashes, mood changes, more anxiety, lower frustration tolerance, feelings of overwhelm that feel out of proportion, brain fog, fatigue that sleep doesn't fix, changes in libido, hair thinning, skin changing, and increasingly research is documenting something that has been underappreciated for a long time: significant metabolic changes. Here's what I want every woman in her late 30s and 40s to understand. Perimenopause is not just a hormonal story. It is a metabolic story, and the two are inseparable. Estrogen is metabolically active. It plays a significant role in how your body handles insulin, where you store fat, how your cardiovascular system functions, and how your brain uses energy. When estrogen levels become erratic and eventually decline, the metabolic consequences are real and measurable. Let's walk through what the evidence shows. First, insulin resistance. Estrogen has insulin sensitizing effects. As estrogen levels drop during the menopausal transition, many women develop increased insulin resistance, meaning their cells don't respond to insulin as efficiently. This can show up as difficulty losing weight despite reasonable diet and exercise, rising fasting glucose, increased cravings for carbohydrates, and more significant blood sugar spikes after meals. The Pittsburgh Women's Healthy Lifestyle Project and other longitudinal studies have documented that women gain an average of 5 pounds during the perimenopause transition, with a shift towards abdominal fat accumulation, even without changes in caloric intake. This is not a willpower issue. This is physiology. Next, let's talk about lipid changes. The menopausal transition is associated with measurable shifts in cholesterol. LDL, the so-called bad cholesterol, tends to rise. Triglycerides can increase. HDL may decline. Apolipoprotein B, a more sensitive marker of cardiovascular risk, also increases. These are not dramatic overnight changes, but they are real, and they are progressive, and they matter for long-term cardiovascular health. Research from the study of women's health across the nation, known as SWAN, documented these lipid shifts specifically in the 1 to 2 year window around the final menstrual period. Most women are not being screened for these changes during this transition. Next, let's talk about bone density. Estrogen is critical for bone maintenance. The most rapid phase of bone loss in women's lives occurs in the first few years after menopause, but it begins during the perimenopausal transition. Women can lose up to 2 to 3% of bone density per year during this period if not monitored and addressed. The ACE guidelines recommend baseline DEXA scanning for women at menopause and earlier screening if there are additional risk factors. Many women do not know their bone density is changing until they fracture something. Now let's talk about something a little bit more nuanced. This is one that I don't think gets enough attention. Estrogen affects thyroid-binding globulin production from the liver. This is the protein that carries thyroid hormone in the bloodstream. As estrogen levels fluctuate during perimenopause, thyroid hormone binding can change. This means that a woman who is on thyroid hormone replacement may find that her dose no longer feels adequate. Her free thyroid hormone levels may have shifted. Women with Hashimoto's thyroiditis, the most common thyroid autoimmune condition, are already at higher baseline risk for thyroid fluctuations, and the perimenopausal transition can amplify that. If you are on thyroid hormone and you are in the perimenopausal transition, it is worth having a conversation with your endocrinologist about whether your dose or monitoring frequency should be adjusted. Next, let's talk about a big one, cardiovascular risk. Before menopause, estrogen provides some degree of cardiovascular protection, influencing blood vessel flexibility, inflammation, and lipid handling. As estrogen declines, that protection diminishes. The ACE and NAMS, the North American Menopause Society, have both emphasized that the perimenopausal transition represents a critical window for cardiovascular risk assessment. Women who have a family history of early onset heart disease, who are developing central adiposity, or who are seeing lipid changes should have a thorough cardiovascular evaluation, not a pat on the back and reassurance that their cholesterol is fine for now. I want to be clear. Lifestyle is not a consolation prize when we are not treating something medically. For many women in perimenopause, lifestyle interventions are genuinely powerful and have good evidence behind them. Let's go through the key ones. First, strength training. This is probably the single most evidence-backed lifestyle recommendation I can make for women in perimenopause and menopause. Resistance training, lifting weights, working against resistance improves insulin sensitivity, preserves bone density, shifts body composition toward more muscle and less fat, and improves metabolic rate. The research here is consistent and strong. If you are currently only doing cardio and you are in your 40s, adding strength training 2 to 3 times a week is one of the most metabolically impactful things you can do. This is not about aesthetics, it's about protecting your metabolic health, your bone health, and your functional capacity for the next 40 years. Next, protein intake. Muscle mass naturally declines with age and accelerates around menopause. Adequate protein intake is essential for preserving that muscle, particularly when combined with resistance training. Most women are under-eating protein relative to what is needed in midlife. General guidance from sports medicine and nutrition research suggests aiming for about 0.7 grams of protein per pound of body weight per day. This is higher than the standard dietary recommendations, which are based on preventing deficiency rather than optimizing muscle health and aging. Now let's talk about diet quality and blood sugar management. The Pittsburgh Women's Healthy Lifestyle Project found that women who followed a Mediterranean or DASH-style dietary pattern during perimenopause were able to blunt the typical rise in LDL and manage weight more effectively than controls. These are not extreme diets. They emphasize vegetables, legumes, whole grains, lean proteins, healthy fats, and reduced ultra-processed food and saturated fat. The common thread is managing blood sugar variability, eating in ways that avoid large glucose spikes and crashes, which become more metabolically disruptive as insulin sensitivity declines. Now let's talk about sleep. Sleep disruption is both a symptom of perimenopause and a driver of metabolic dysfunction. Poor sleep directly worsens insulin resistance, increases cortisol, elevates hunger hormones, and makes it harder to maintain a healthy body weight. Treating sleep disruption in perimenopause is not optional. This may mean addressing the underlying hormonal cause, which is a conversation worth having with a physician. It may also mean sleep hygiene, cognitive behavioral therapy for insomnia, or other targeted interventions. But dismissing sleep issues in perimenopausal women as just stress misses a significant metabolic lever. Now let's talk about when we should consider menopausal hormone therapy, or MHT. I want to address this carefully because it is a topic surrounded by both legitimate nuance and a lot of fear that I think has been overblown. Menopausal hormone therapy, MHT, is not right for everyone, but the 2022 ACE position statement on menopause and subsequent updates have reiterated that for women who are symptomatic, who are under 60, and within 10 years of menopause onset, and who do not have specific contraindications, MHT is an evidence-based treatment with favorable risk-benefit profiles. The fear surrounding hormone therapy largely stems from a misinterpretation of the original Women's Health Initiative data that was collected in older women who are well past menopause and used a specific oral formulation that is not what most physicians are prescribing today. Transdermal estradiol, used appropriately, is not the same as the oral conjugated equine estrogen studied in the WHI. These are different molecules, different delivery mechanisms, different populations. If you have been told you cannot or should not use hormone therapy and you have not had a thorough, individualized conversation about your specific risk profile and you are symptomatic, it is worth seeking another opinion. I want to give you some concrete tools to take into your next appointment, because the healthcare system is not always going to proactively offer you this conversation. Sometimes you have to start it. If you are in your late 30s or 40s and you are experiencing any of the following: changing periods, sleep disruption, mood changes, unexplained weight changes, brain fog, fatigue, it is entirely appropriate to say to your physician, "I think I may be in perimenopause. Can we talk about that?" Specific things worth discussing. Has anyone checked your fasting lipids recently? If not, and you are 40 or older, it is time. Has anyone talked to you about your bone health? A baseline conversation at least, if not a DEXA scan, depending on your risk factors. If you are on thyroid hormone replacement, has your dose been reevaluated given any recent hormonal changes? And if you are symptomatic, if you are not sleeping, not feeling yourself, gaining weight despite doing everything right, is there a discussion to be had about whether menopausal hormone therapy is appropriate for you? You deserve a physician who will have that conversation with you rather than attributing everything to stress or telling you to exercise more. And if you are not getting that, it is okay. In fact, you should seek out someone who specializes in this transition. Perimenopause is not a warning sign of decline. It is a turning point, and the women who navigate it best are the ones who understand what is happening in their bodies early enough to do something about it. The metabolic changes that begin during this transition, the insulin resistance, the lipid shifts, the bone density change, the cardiovascular risk profile, are not inevitable fates. They are signals, and they respond to intervention. Lifestyle intervention, medical management, and individualized care can make a real difference if you know to ask for it. We will keep going deeper on all of these topics here on Endocrine Matters. If this episode raised questions about your thyroid function during this transition specifically, go back and listen to our episodes on thyroid care with Dr. Ruchi Gaba at Baylor College of Medicine, and our episode on thyroid misinformation with the doctors on my team, Dr. Alluri and Dr. Mehta. And if you have been told your labs are normal but you still feel terrible, our episode on compassionate thyroid care was made for you. I'm Dr. Thangudu. Thanks for listening. Share this one with every woman in her 40s who deserves to understand what is happening in her body.